all to the CME on breast cancer. I think it's the perfect start for this month of October, which is observed as National Breast Cancer Awareness Month. I welcome I welcome the chief guests, chairpersons, and all the speakers to the dais. And I would request Dr. Devtade, IMA Chief Nagpur, to kindly give a welcome address. Thank you.
Am I audible?
Yes, you are.
Namaskar. Respected chief guest, our Guru, Shri Das Gupta sir, is a director, medical services and dean, academics, Kingvia Hospital, one of the largest private hospital in central India. Today, chairperson, again our Gurus, Dr. Sunil Lanjewar sir, professor and head, Department of Surgery, IGGMC, and Dr. Sudhir Deshmukh sir, who is also President, Association of Surgeons of Nagpur. Highly qualified speakers, with special mention of Dr. Sandeep sir from Chennai, a great innovator, and who has also patenting of sentinel lymph node biopsy. MOC Pratibha Madam ji, Dr. Shahna Chimthanwala Madam, जिसपे IMA को नाज है, and who have coordinated this CME, all learned participants. Breast cancer, one of the topmost cancer in female, taken upper hand over CA cervix in last few years. Although CA breast thought to be curable cancer, it has to be diagnosed in early stages. Let's add recent advances to our knowledge bank so as to make it CA breast 100% curable. Being October Breast Cancer Awareness Month, forget shyness, shame, and pleasure thoughts. Go check up your breast or flirt with an mammogram. Jai Hind, Jai IMA, Nagpur. Over to you, MOC Madam.
Now I would like to welcome our chief guest, Dr. Das Gupta. I think I have this proud privilege to welcome our chief guest today. Dr. Das Gupta is a well-known figure in the field of surgery. He doesn't need any introduction though. Still, sir has been professor of surgery for past 20 years, and he has a whooping 30 years experience in surgery, and he has multiple publications in index journals, national and international presentations. Sir has been the dean of NKP Salve for past 9 years, and then he is presently working as Director Medical Services in Kingsway Hospital itself. Apart from his academics, he has a whooping administrative career also. And sir has given a lot of orations. He's like prestigious Baliram Dubey oration in MapCon 2015, Dr. K.C. Gharpure oration in Massicon 2015. He has multiple publications in international journals as well. I welcome you, sir, and I request you for your words of wisdom. Thank you.
Thank you, everybody. At the onset, my thanks to the IMA for having invited me as chief guest on an occasion which is very, very important, not only for the surgeons, but for the whole of the medical fraternity. So, seated on the dais, the president of the IMA, Dr. Devtade, secretary, MOC, the chairpersons of today's CME, and the speakers. Now, you're all very learned audience, and I'm not going to speak anything about the cancer breast as such, but with a few questions which still arises in my mind as to why we are unable to conquer on this disease, or at least bring it to a level of some sanity, because we always talk of lack of awareness. Lack of awareness amongst whom? Of course, when we say lack of awareness, we mean that it is the lack of awareness amongst the general public. But I have been, as a surgeon, observing this disease in last 3 decades. And if you see the statistics of Globacon 20, both international as well as the statistics released by the Indian authorities, you will see that there has hardly been any visible change for the good as far as cancer breast is concerned. What I feel is that just a tokenism of celebrating Breast Cancer Month once a year is just not enough. In fact, as you all know, that breast cancer has overtaken all cancers of the body and is now the number 1 cancer and the number 1 cancer amongst women and the number 1 killer amongst women. And therefore, breast cancer awareness should be done every day, 365 days in a year. As far as India goes, the statistics are not that properly accumulated, and still there are very few centers which have authentic statistics. So I am sure that the figures which we get through Globacon 20 and the ICMR and the other bodies which are presently giving us the statistics fall short of the actual numbers. And these numbers may be nearly double if really they all cross across the country, they are properly recorded. My appeal to IMA is that as far as breast cancer is concerned, and if the medical fraternity is really serious about doing its part of the job, and IMA being in a very good position and a nodal body, we should seriously think of starting a breast cancer registry in the city of Nagpur. I recollect Dr. Madan Kapre had started a thyroid cancer registry in the city of Nagpur on his own individual initiative. So there is no reason why IMA as a body or taking ASN or the Surgeons Association and the Association of Pathologists together can undertake this responsibility. I am sure there may be many hurdles in its way, but at the end, it will certainly have an impact and give us a much more authentic view of the prevalence of this disease. Thereby, it will also contribute to the national statistics and as far as the statistics of the local region is concerned. Breast cancer has been a challenge worldwide and in India also. In India, we are facing a very peculiar problem in the sense that breast cancer occurs in much younger age group as compared to the Western world. Not only that, the breast cancer which we see in India is of much aggressive nature, and therefore it is more difficult to treat. The outcomes are poor. One of the main contributing factors, of course, being the late stage of the disease at the time of detection. I must appreciate IMA for having taken the initiative to hold today's CME, and with stalwarts in the field of breast cancer, I am sure there is going to be a very interesting deliberation on this topic, which will enlighten all the audience, the practicing surgeons, pathologists, radiotherapists, medical oncologists, and also the postgraduate students who are a witness to today's CME. I wish this CME a very big success, and congratulations to the organizers once again. Thank you.
Thank you for the kind words, sir. May I now request Dr. Devtale to present the e-memento to our chief guest, Dr. Dasgupta.
Piyush.
Thanks for sharing.
Sir, thank you very much.
Thank you, Dr.
Just,
Dete. Thank you, all of you. Thank you so much.
just last week, we have launched a cancer registry at RST Cancer Hospital.
The RST Cancer Hospital has a PBCR and an HBCR already under the guidance of the ICMR. Yes, RST is doing a good job as far as the patients being generated in RST. But I'm sure you say breast cancer is a disease which is being treated by probably every nursing home in Nagpur. And therefore, these sporadic cases which are being done in isolation, so they are not being recorded or reported. So they also form a sizable number. So if some mechanism can be developed by which, say, for example, some surgeon is operating a CA breast in his or her own nursing home or clinic, they should have a platform and to report such cases. So I am sure you can do it. You can take help of Dr. Madan Kapre sir. He has done this very nicely. And of course, you can contribute and to the main pool. Because what I believe that there's a Nagpur Cancer Society as well. But again, I mean, there is a total disconnect between that Nagpur Cancer Society, RST. Sevagram Medical College is doing an excellent job. I have visited that college, visited their PBCRs and the HBCR cell, and they are doing a very good job in a very organized manner. So this whole region of Vidarbha, I mean, forget the rest of the part of the country, but at least in Vidarbha, we can have a really good, authentic statistics if we work in that direction.
Yes, sir. Definitely, IMA will try their best to rejoin all these organizations for the betterment of people. Thank you.
Yes.
Moving forwards, I would like to introduce our chairpersons. Today, Dr. Lanchevar, he is the professor IGJMC, and he has been acting dean in 1994 Dhule, and also for a short period in Akola and Nagpur. He has been a postgraduate teacher for long. He is member of renal transplant team since 2002 to 2009, and presently as a consultant surgeon at Dada Saheb Lanchevar Hospital. Along with him, we have Dr. Sudhir Deshmukh, who is director and in charge of oncology, Getwell Hospital. He has specialty training in oncology, and presently is also the president of Association of Surgeons of Nagpur and honorary cancer surgeon at Rashtra Sant Tukdoji Tertiary Cancer Care Center. He has a lot of scientific presentations in different meetings in different conferences of IMA at various places. I welcome you both, sir, and I would like to hand over the mic to you for the further proceedings. Thank you.
Can you hear me, Dr. Dasgupta?
Yes, sir.
Am I
Yes,
audible?
yes.
Yes, sir. Yes, sir.
Yes, welcome, Dr. Lanchevar.
Should we start or should we wait for some time?
We can start now, sir.
Who is going to be the first speaker?
Dr. Bomanwar.
Dr. Bomanwar, okay. You are going to be the first speaker.
Yes, sir.
Where is the link gone?
Audible. You are audible as well as visible.
Okay, Director, Dr. Dasgupta, should we start?
Yeah, please start. Go ahead.
At the outset, I thank IMA, Nagpur branch, Association of Surgeons, Nagpur, and Kingsway Multi-Speciality Hospital for holding this CME on a most important topic of carcinoma breast. Carcinoma breast continues to be one of the most important cancer as far as the human beings are concerned. It is roughly estimated that the 8th or 9th woman in the world is likely to suffer in her lifetime from carcinoma breast. There are so many innovations. If you see the history of carcinoma breast, is management from ultra radical, not radical, ultra radical operative procedure, it has come down to more breast conservative surgeries. This is possible only because of understanding of the tumor biology, immunology, advances in radiotherapies, then advances in chemotherapies. All these has made the survival rate in a carcinoma breast as a tremendous change. When we were a student, we used to talk the 5-year survival and at the most 10-year survival. But now you talk of 20-year survival only because of multimodality therapy, which is the crux of treatment of malignancies at present. So in today's CME, all these aspects will be talked, and we have got luminaries in the field of oncology, surgical oncology, radio oncology, etc. So let me introduce Dr. Bowman Watt, who is the oncosurgeon. He has done his MBBS from GMC Yavatmal and then has done his MS from GMC Nagpur. Later on, he has done MCH oncosurgery from the Gujarat Medical College, Cancer Institute of Gujarat, and now he is a consultant at so many places. He has worked in a American Oncology Society, RST, then at from last 3 years he is at the Kingsway Multi-Speciality Hospital, and he is also visiting surgeon at so many places. I hand over mic to Dr. Bowmanwar, who is a very enthusiastic oncosurgeon, and let us see what he wants to say regarding surgical aspect of the carcinoma breast. Over to Dr. Bowmanwar.
Thank you so much, sir. Uh, Good evening, everybody. Good evening, everybody. Are you audible?
Yeah, you are audible to me.
Sir, make it a full screen. Make it a full screen. Slide
Yes.
PPT.
PPT full screen.
Yeah.
Very thankful to IMA and ASN for giving me this opportunity.
And Kingsway.
Today, I am going to talk on advances in breast cancer surgeries. As far as the incidence is concerned, Dr. Dasgupta already told, but I want to share something. Breast cancer accounts for about 14% of cancers in Indian women, and every year about 2 lakh cases, new cases were detected, and about breast cancer is responsible death of about 1 lakh breast cancer patients. Main problem is the late detection of the breast cancer. Most of the patients, about 50% of patients, come with advanced stage, that is stage 3, stage 4 disease. So we have to increase awareness of breast cancer for early detection. I will not go in details of anatomy, as a breast is a modified afferent sweet gland, Composera passina, which forms lobules, and aggregation of lobules from lobe. About 15 to 20 lobes drain into lactiferous ducts. These lactiferous ducts are lined by stratified squamous epithelium. The main aim for management of operable breast cancer is to achieve local control. And as far as surgery is concerned, there is we can do wide local excision and modified radical mastectomy, and adjuvant treatment in form of chemotherapy, radiation therapy, and hormonal therapy. Main aim of treatment for early breast cancer is to achieve cure, local control of disease, to maintain form and function, and to prevent and delay the occurrence of distant metastasis and local recurrence. So I want to share something about breast conservation therapy. Breast conservation means we are removing the tumor with wide local margin. We are taking about 2 centimeter wide margin of normal appearing breast tissue, and we can call breast conservation therapy as a wide local excision, lumpectomy, segmental mastectomy, or partial mastectomy. For stage 1, stage 2 breast cancer, breast conservation therapy is preferable to total mastectomy, as it is equivalent for oncologic safety and also for survival rates, and in terms of quality and aesthetic outcome also. Breast conservation surgery allows for preservation of breast shape and skin, as well as the preservation of sensation. Breast conservation surgery is a currently standard mode of treatment for stage 0, that is ductal carcinoma in situ, stage 1, and stage 2 invasive breast cancer. Breast cancer therapy allows for preservation of breast shape, skin, as well as the preservation of sensation. Same slide is there. The main advantage of breast conservation surgery is to improve the cosmetic appearance of the breast, to decrease the psychology morbidity in females, that is anxiety, depression, that self-esteem, as compared to mastectomy, and equivalent in terms of disease outcome as compared to the modified radical mastectomy. There are few indications. We can do breast conservation in early breast tumors, T1, T2, where T2 more than 4 cm in large breast women, and clinically and mammographic single lesion. It is contraindicated in mostly stage 4 disease with N2 nodal and metastatic disease, but we can prefer mastectomy in patients' preference. And relative contradictions for breast cancer surgery are multifocality and collagen vascular disease and the family history of breast cancer. When we remove the about less than 5% of breast volume, there is no need to mobilize the breast. It is closed very well and with good cosmetic result. But when more than 10% of breast volume is removed, then we need reconstruction for better cosmetic outcome and function. As if we remove breast tumor more than 10 to 20%, it will lead to seruma absorbs, which absorbs and leads to contracts, and after radiation, it will leads to ugly distorted breast. I want to tell something about sentinel lymph node biopsy. Dr. Sandeep will might enhance this sentinel lymph node biopsy. Sentinel lymph node biopsy may be considered when there is a probability of finding invasive cancer on final pathology examinations. Some surgeons perform sentinel lymph node biopsy all patients with ductal carcinoma because sentinel lymph node biopsy cannot be performed post mastectomy, as there may be chances of occult invasive cancer may be there. Sentinel lymph node biopsy should be avoided where the primary tumor is greater than 5 cm, or a patient underwent previous surgery, or he got radiation therapy, clinically palpable axillary lymph nodes, and a multifocal tumor. Approximately 30% of patients with clinical negative examinations have positive lymph nodes in axillary lymph node dissection specimen. The presence and number of lymph nodes involves affect the stage and the prognosis of the disease. However, complications are not infrequent. So, as benefit of sentinel lymph node is that we can prevent the lymphedema following the axillary lymph node dissection. decreased sensitivity over the back of chest and the upper chest. So there are few benefits as far as the central lymph node biopsy is concerned. In our institute, we are using the ICG fluorescence technique, that is 5E, for identifying sentinel lymph nodes in a primary draining axillary lymph node basin. We first inject about 0.25 ml of ICG at 12 o'clock and 9 o'clock position for our right breast, and 12 o'clock and 3 o'clock position for left breast subdermally. We give mild massage at injection sites. Then after 5 minutes, we'll trace for lymphatic. Where the lymphatics drainage stop, there we give the small incision about 2 centimeter. This ICG fluorescence technique is based on non-ionized laser blaze fluorescence. So these images are to showing where on a color-based technique, it looks like a pinkish blue, and on contrast mode, it looks like the illuminated white spot. We remove this node, about 2 to 3 lymph nodes are removed, and we send for frozen section. If on frozen sections nodes are positive, then we have to do the axillary lymph node dissection clearance completely. Yeah, and if it is negative, we can avoid axillary lymph node dissection and the morbidity of the axillary lymph node dissection. So sentinel lymph node is identified by its blue color. Previously, we are using methylene blue. So I'm telling something. So identify blue color and high activity detected by handheld gamma probe and by blue lymphatic stain entering that node. So about 20 to 30% of time, more than one sentinel lymph node is identified. I already told, if the sentinel lymph node is positive for metastasis, then you have to do the complete axillary clearance. And if it is negative, we can avoid the axillary clearance, preventing the complications of the axillary dissection. So I can dive into about the oncoplastic surgery in breast cancer, which broadly refers to the reconstruction of the partially removed breast in case of when we are doing the wide local excision or lumpectomy. Mostly in the small breast, if we are doing the lumpectomy or quadrantectomy, it is very difficult to reconstruct that breast because breast volume is very low. So variety of techniques we are using for partial mastectomy reconstruction, including local tissue rearrangements, reconstruction through reduction mammoplasty and mastoplasty, and transfer of procoregional flaps. One current major limit for lumpectomy is the skin and tissue deformity, influencing the ultimate cosmetic outcome. However, the percent of breast volume exercise is the single most important factor for influencing the cosmetic outcome. Aesthetic outcome lagged behind, securing improved local control and overall survival. Following standard breast conservation surgery, up to 40% of the complaint of unsatisfactory cosmetic outcomes are possible. Most important is the tumor to breast ratio is the strongest predictive factor for poor outcome. When we remove about more than 20% of this breast tissue, the outcomes are very unfavorable. Large breasts with various grades of ptosis may also adversely impact the result of breast conserving surgery, but reduction or mammoplasties are very good in the large breast. Patients-related factors like diabetes mellitus, collagen vasculitis also affect the oncoplastic surgeries. Preoperative evaluation for oncoplasty is very necessary as far as the breast size and tumor breast ratio is concerned. In smaller breast tumor, there is a less glandular tissue available to perform local tissue rearrangements, and therefore these patients are more likely to need regionally blessed flaps. Larger breast tumor have more options available for reconstruction, whether it is local tissue rearrangement, local or regional flaps, or reduction mammoplasty or mastopexy. We have various oncoplastic techniques for breast reconstruction, volume replacements methods like latissimus dorsi, musculocutaneous flap, cramp flap, and deep inferior epigastric artery breast flap, and breast reshaping techniques including reduction mammoplasty and rotation flap. This image is showing various volume replacement and volume displacement reconstruction surgeries for breast. In local tissue rearrangement surgeries, there is an essential component of many oncoplastic technique. It is commonly used in women with moderate size breast, small tumors, and grade 1 ptosis. And mastopexy is mostly used in larger breast volume as well as the significant ptosis, patient is having significant ptosis. Bilateral reduction mammoplasty is an ideal treatment option for breast cancer women with previous macromastia. And one of the amount required tissue resection is determined its lateral side. This image is showing the reduction mammoplasty, where the shaded area A is showing. We are excising this portion. Then we are removing skin over the B area. We are removing about 1 centimeter skin surrounding the nipple for mobilization. Then reconstructed nipple goes to A area, and we close the defect by closing C and D closure. In lower quadrants, we are removing the small tumors in donut shapes with wide margin. Then we have to mobilize nipple areola complex by 1 centimeter removing skin, then mobilizing breast area from inframammary fluid and closing the defect. These are various oncoplastic techniques, mammoplastic techniques, as far as the location of the tumor is concerned. So volume replacement and volume displacement is selected according to whether the target breast was ptotic or non-ptotic, respectively. And patients with cancerous lesions located on the upper inner area of the non-ptotic breast, the volume displacement was not adequate from cosmetic perspective, and volume replacement using latissimus dorsi muscle flap was also not adequate from the complexity of the surgical procedure. Through oncoplastic breast surgery, patient only had their cancerous lesions removed, but an achieved symmetric and cosmetic breast can be achieved. So by in early breast cancers, by oncoplastic reconstruction, we can give patients the cosmetic appearance of breast by reduction mammoplasty on other side also. Thank you. Hello.
Hello. Sudhir,
Yes, sir.
any questions? Because on chat box there are no questions. I could not see
Okay,
any
okay.
questions.
Sorry, because of unavoidable reasons, I could join a little late. Being the chairperson, I had to join prior, but sorry for that. Can I ask something, Dr.
Yeah.
Bowman?
Yes, sir.
Yeah. So, no doubt the most accepted treatment for all breast cancers in early, the cosmetic breast preservation is most important, and that is most accepted. But do you often see that opposite side reduction mammoplasty? How often the patient accept that?
We are telling women to undergo reduction mammoplasty on other side, but most about 90% of females are avoiding these things. She is not ready for a reduction mammoplasty on other side.
Yeah. Yeah, practically speaking, we have observed that in the last 100 years, we have come from very wide excisions, means very radical surgery, from heart stage surgery to today's breast conservation surgery,
Yes,
where keeping the oncological principles sound and well preserved, we try to preserve the breast completely so that the patient has a good cosmesis and the good aesthetic sense, so that she doesn't have any depression or the a mental shock because of the treatment or by losing the breast. So no doubt the breast conservation surgery has come very widely in last 25 years, maybe because of the better understanding of the disease, better understanding by the molecular biology, and the better surgical techniques and radiation oncology. So no doubt patients are being benefited very well. The only thing, the next step in the breast conservation surgery has come the oncoplastic surgery, right?
Yes. Yes.
So in oncoplasty, the local flaps are most important. So what is your experiences in oncoplasty?
Yes, sir. Mostly we are using local regional flaps, and if a young female is there, she is ready for oncoplastic surgery, we are doing oncoplastic surgery. But very few women are willing for oncoplastic surgery for mobilizing and reduction mammoplasty on other side.
Do you have any experience that because of the oncoplastic surgery, the further adjuvant treatment is delayed, or patient is delay of the surgery?
Very rarely, sir.
Yeah.
Yeah.
Okay. Yes, Lanjar sir, can we shift to second speaker?
Yeah.
Yes.
So, Dr. Prasad, you are going for a second.
So sorry to interrupt, sir. Can we? I request you to please present the e-moment to Dr. Nitin Bhumanwar, sir, please.
Yes.
Yeah,
Okay.
yeah.
Right.
Good presentation, Dr. Bowmanwar.
Yeah.
Now we will switch over to medical oncology. And today's speaker is Dr. Saurabh Prasad. He is undergraduate student of Baroda Medical College. Then he has done his MD from the Ahmedabad Medical College, BJ Medical College, Ahmedabad. Sorry, NHL, Srimati NHL Medical College, Ahmedabad. And after that, he has done his DM, Medical Oncology from Gujarat Cancer and Research Institute of DJ Medical College. He has got a wide experience, and before joining Kingsway Hospital, he was a medical oncologist at the RST Nagpur, and he has got a wide experience in bone marrow aspiration, refined biopsies, lumbar punctures, intrathecal injections, chemotherapy of various malignancies. And here we present to you, he is going to talk on medical oncology as per the carcinoma breast is concerned. Over to Saurabh Prasad. Dr. Saurabh Prasad.
Good evening, everyone. Yeah, I would like to thank IMA and Association of Surgeon Nagpur for giving me an opportunity to speak on one of the topic which is very close to my heart, and almost 60% of my practice is related to breast cancer. And over the last few years, there has been a lot of progress in the medical management of breast cancer, particularly starting from the metastatic disease. And now these all changes are now being translated into early breast cancer and in curative setting. So I would like to start my presentation. Is the presentation visible?
Yes.
So I would be going to speak on the advances in the medical management of early breast cancer. Because of limited time and very vast topic, I would be just summarizing the changes which has taken place in the last 4 or 5 years in the management of early breast cancer. Many of the things would be a repeat, but few of the things which I would be presenting are latest and are practice changing. And these have changed in the last 4 or 5 years from the days I were in the college. From now, there has been many changes which I have to undergo in the management of early breast cancer. So everybody knows how to diagnose and clinically stage breast cancer, but I have highlighted one of the important change which has taken place in the last few years, and which I would like everybody to inculcate into their practice. That is, all patients who present with a breast cancer should undergo a biopsy to determine ER/PR HER2 even before undergoing surgery. This is very important in the management of early breast cancer. Future slides would be dedicated to these, but this is one of the practice changing thing that now FNSC should not be the standard. All breast tumors should undergo a biopsy, and the surgery should be held till we don't get the ER/PR HER2 report. There are a few exceptions where we can do a surgery, which I would be later on going into detail. So here you can see that all tumors after biopsies should should undergo ER/PR HER2 testing, and there are criteria for the pre-operative systemic therapy for all patients. So I would be going only for the early breast cancer. So what are early breast cancer? These are breast tumors which are T1 to T3 and node negative or N1. So all tumors of stage 1A, 1B, 2A, 2B, and T3N1 of stage 3A are called early breast cancers. So as I told you before, that we should undergo ER/PR HER2 testing for all patients, and this is because we have to consider pre-operative systemic therapy for early breast cancer. So who are those who require these pre-operative systemic therapies? Even in operable breast cancer, these are patients who are HER2 positive or TNBCs whose tumor are more than 2 centimeter or whose lymph node are positive. So any tumor with more than 2 centimeter in size or any node positive should first undergo a biopsy to determine whether they are ER/PR positive or triple negative. These two subset of patients comprises almost 50% of our practice, and these patients should undergo a neoadjuvant chemotherapy, because giving neoadjuvant chemotherapies to these patients increases their survival, which I would be speaking on in the later slides. Those large primary tumors relative to the breast size in those patients who desire breast conservation may require neoadjuvant chemotherapy even if they are operable. And those patients who are node positive and are likely to become node negative by giving pre-operative systemic therapies. So these are the subset of patients in early breast cancer who require neoadjuvant chemotherapy. So as I told, there are benefits of giving neoadjuvant chemotherapy in early breast cancer. The treatment response provides important prognostic information at individual patient level, particularly in patients with TNBC and HER2 positive disease. Giving a neoadjuvant chemotherapy identifies those patients who have residual disease after completing the whole neoadjuvant chemotherapies, and these patients are at higher risk of relapse, and identifying these patients allow us to give additional supplementary adjuvant regimen, particularly those who are triple negative or HER2 positive. So in the later slide, I would be speaking about the treatment plan, but you can see that those early breast cancer which are operable, but these all patients who are HER2 positive or triple negative more than 2 centimeter should undergo a neoadjuvant chemotherapy. So in this flow diagram, you can see that all the early breast cancers, those tumors who are less than 2 centimeter and are feasible for surgery can undergo breast conserving surgery or a MRM depending upon the patient's choice. But those tumors which are more than 2 centimeter and they are optimal for breast conservation after reducing the size should undergo downstaging. and particularly those patients who are TNBC and HER2 positive or with axillary node should more than 2 centimeters should undergo systemic therapy. So these are the patients who should receive neoadjuvant chemotherapy. So coming to the prognostic and predictive measures of therapeutic benefit in hormonal receptor positive early breast cancer and those who are HER2 negative. So you can see that those who are hormone receptor positive and HER2 negative, these are the this is chart for the postmenopausal female and a similar chart for the premenopausal female. You can see that those patients whose tumor are more than 0.5 centimeter and node negative or node positive should undergo a oncotype DX. This is a genetic testing which is done on the biopsy specimen, and this is a 21 gene RT-PCR assay to determine the risk of recurrence. Though this test is very expensive, but over the years we have found that we are over treating breast cancer patients with chemotherapy. There are large number of patients who do not require chemotherapy in early stage, and many of the postmenopausal female even with node positivity may not require chemotherapy. So this is one test which has come in the last 5-10 years, and those patients who don't undergo these tests require ideally a chemotherapy and endocrine therapy, but those with a low recurrence risk score of that is less than 26 can be given only endocrine therapy and no chemotherapy, and those with a high risk score can should be given chemotherapy plus with endocrine therapy. A similar chart is for premenopausal, but the only change is that those who are node negative T1 to T3 disease should undergo this oncotype DX testing, and based on the recurrence score we can omit chemotherapy in low score which have less than 15. For intermediate, chemotherapy may or may not be given, which can be discussed with the patients, and in the future next slide I will be showing what is the minimal advantage of giving chemotherapy in these subset, and those with high recurrence score will require chemotherapy followed by endocrine therapy. So the RS Clin this is a prognostic test also known as oncotype DX, and this provides greatest prognostic information compared to the clinical pathology markers as well as other recurrence score. It has been prospectively as well as retrospectively studied in more than thousands and thousands of patients, and there has been randomized trial of TaylorX as well as RX Ponder to determine which patient do not require chemotherapy. You can see in this chart that here are the recurrence scores, and these are the postmenopausal female. So a postmenopausal female only with a recurrence score of more than 26, even if they are node positive, these are the only subset of patients which require chemotherapy. So we can see that majority of the patient may not even require chemotherapy. In the premenopausal female with the node negative, you can see that a score up to 15 may not require chemotherapy, and between 15 to 25 there is only very small advantage ranging from 0.2 to maximum 8% improvement in the survival. So these patients can be counseled. Few of these patients may not even require chemotherapy if they wish. Node positivity, the advantage is very small in the low recurrence score. It is just 4% and 6.2%. So this is one of the tests which has come up and very widely used in the Western world, and in this help to stratify those patients who do not require chemotherapy. So basically we are over treating many of the patients by giving chemotherapy. Now coming to the HER2 positive early breast cancer. So there has been many changes which has taken place in the HER2 positive breast cancer, and we would be dividing into the choice for neoadjuvant chemotherapy, the choices of adjuvant based on the response to the neoadjuvant chemotherapy, and those patients who require extended adjuvant therapy. As I previously told, any patient with a tumor size of more than 2 centimeters in diameter or node positive, HER2 positive disease should receive neoadjuvant chemotherapy with trastuzumab plus minus pertuzumab. Pertuzumab is one of the another HER2 targeted therapy, and adding pertuzumab to trastuzumab improves the overall survival of the patient. So those patients who have received neoadjuvant chemotherapy, they will require adjuvant targeted therapy. So those patients, those who are at high risk, HER2 positive, node positive, who have undergone primary surgery, these all will require pertuzumab plus trastuzumab to be completed for 1 year. Those patients who have received neoadjuvant chemotherapy and had a complete response, no residual disease in the pathological sample, should complete their 1 year of pertuzumab plus trastuzumab as adjuvant. Those who have not been added pertuzumab in the neoadjuvant therapy should receive it with trastuzumab in the adjuvant setting. There are few subset of patients who do not achieve complete CR and have residual disease after neoadjuvant therapy. These patients should receive TDM1, Kadcyla, and now we have an Indian generic biosimilar of TDM1, which should be given for the next 14 cycle to complete 1 year of adjuvant treatment. There are subset of patients who require more than these, and these are node positive patients, HER2 positive and estrogen receptor positive patient who have completed 1 year of HER2 targeted therapy should receive niratinib, which is an oral anti-HER2 therapy to be given for 1 whole year after completing the injectable 1 year of HER2 targeted therapy. This is the phase 3 trial where niratinib has been proven to improve, statistically improve the invasive disease-free survival of the patient when it is given for an extended 1 year of adjuvant treatment. So these are the new developments in the last few years in the targeted therapy for HER2. And as I have previously told, niratinib has got an FDA approval in 2017. On the same year, we got approval for adjuvant trastuzumab plus pertuzumab, and in 2019, those patients who have received neoadjuvant therapy and have a residual disease should receive TDM1 to complete 1 year of anti-HER2 therapy. So you can see in this graph that those patients who are T1A1B node negative can undergo surgery and complete their adjuvant treatment. Those with T1C, we can discuss with patient, they can undergo surgery followed by adjuvant, or they can undergo neoadjuvant therapy. All patients with T2 disease or node positive should receive neoadjuvant chemotherapy with anti-HER2 therapy. Those patients achieving a pathological CR should complete 1 year of targeted therapy followed by niratinib, and those hormonal receptor negative should receive only 1 year of targeted therapy. Those with residual disease should complete 1 year of targeted therapy with TDM1. Now coming to TNBC, as I told that these TNBC patients should also receive neoadjuvant chemotherapy, and the reason for this is this trial. This is the CREATE-X trial. It has been found that those patients who had residual disease after receiving neoadjuvant was at very high risk of having relapse. So this phase 3 study was conducted in these patients who had residual disease, and the conclusion of this study was that giving 6 months of capecitabine to these patients after completing neoadjuvant chemotherapy having residual disease improved their survival. So as I previously told, all early breast cancer patients should undergo biopsy, determine their ER, PR, HER2 before subjecting them to surgery, because all patients with either HER2 positive or TNBC should receive a neoadjuvant chemotherapy in today's era. So now the newcomer into the treatment is the role of PARP inhibitors in those with germline mutation for BRCA1 and BRCA2 in early breast cancer. We all know that PARP enzyme inhibition leads to the cell death in those cells which are deficient in homozygous recombinant repair, particularly the BRCA1, BRCA2. BRCA1, BRCA2 germline mutation is found in almost 5% of hereditary tumors, breast cancer tumors, and they comprises almost 95% of the mutation found in the hereditary group. So this year in the annual conference, this Olympia A trial was presented. This is a phase 3 study where the patient with TNBC or HER2 positive subgroups, those who were having germline mutation for BRCA1, BRCA2 were given 1 year of olaparib. Olaparib is one of the PARP inhibitor which is available in the market, and it was found that it improved the survival as well as DFS. It improves the DFS. The survival data is still not out. So it improves, statistically improves the invasive disease-free survival of these patients who are BRCA positive. There are many unanswered questions. Over the last few years, there has been multiple medicines which have been launched for metastatic disease, and these have been found to improve the survival of the metastatic breast cancer patient. And now these drugs are being studied in the early breast cancer setting. And one of the important drug is the CDK4/6 inhibitor. There are 3 such medicines in the market, that is palbociclib, abemaciclib, and ribociclib, and they have been studied, and these are the 4 trials. 3 of them have been reported, and one of the study, Monarch E, have shown to improve the survival, 2-year survival of the patient. Long-term data is still pending, but the other 2 trials were negative. So the problem is that in all the 3 trials, the subjects, high-risk patients were taken, but the criteria were very different, and they were given for different interval of time. So at present, we don't know for whom we should give this medicine and for what duration we should be giving. So there are ongoing almost 5-6 different studies with different combination, different timeline, and for different subset of patient to determine which early breast cancer patient may have more survival by giving the CDK4/6 inhibitor. Similarly, this CDK4/6 inhibitor is being tried in the neoadjuvant setting. These are the few trials which are being studied in the neoadjuvant setting to determine whether giving this neoadjuvant therapy improves the overall survival, have more pathological response, complete pathological response in these patients or not. Coming to the immunotherapy, over the last 5 years, there has been boom in the treatment of metastatic cancers, and immunotherapy is one of the drug which is used in triple negative breast cancers, and this at present only in metastatic disease, and there are multiple ongoing trials to determine whether this neoadjuvant chemotherapy or adjuvant immunotherapy will improve the survival of this triple negative breast cancer patient, which overall have very poor prognosis. Thank you. Thank you for patient listening.
Now, my one question is, you said that 21 RT-PCR is going to help to segregate a patient who is likely to get benefit after the neoadjuvant of chemotherapy.
No, sir.
No.
That 21 gene assay is to determine those patients who do not require chemotherapy.
Yeah, that means you are going to segregate a patient who requires and who do not require.
Yes, sir.
No, where it is being done and what is this cost and what is its reliability? These three important questions.
Yes, sir. Sir, there are multiple such tests and few have been indigenously developed in India also. I have mentioned only one test because this is US FDA approved and this is done in US. So the sample is to be sent in US. The cost at present is ranging from 2.5 lakhs to 3 lakh rupees for the test, and the report comes in 6 to 8 weeks. There are some indigenous similar tests and by Indian labs, but their database are small and we are not very confident whether by testing those females and omitting their chemotherapy and in future if there are relapses, so our Indian FDA have not approved properly to those tests. So though they are used, but we are not very confident on Indian test, but this Oncotype DX has been time and tested. It is in the market for almost more than 10 years and it has been authenticated in multiple trials and they have a database of more than 50-60,000 patients.
Now, this was all right for neoadjuvant chemotherapy before surgery.
No, sir.
Now, what about adjuvant chemotherapy?
Sir, this is for adjuvant chemotherapy. Those ERPR positive patient will undergo surgery in the early breast cancer, and when their sample will come, this sample would be sent for Oncotype DX testing. If their recurrence score is high, they will require chemotherapy, and low may be segregated into endocrine therapy, and premenopausal with node positive will require chemotherapy. So this is only for ERPR positive, HER2 negative early breast cancer.
Yeah. And what about does this test has got any importance in adjuvant chemotherapy for other breast cancers? Leave apart early breast cancer?
Sir, this has been tested for this is used only for early breast cancer, hormone receptor positive, HER2 negative. This test can't be used for HER2 positive diseases and TNBC. So this is selectively for those patients who are hormone receptor positive.
Okay. So
it is not used for advanced diseases.
Right. Very well presented, Dr. Saurabh. Yeah.
Thank you, sir.
You are reducing surgeons' work day by day. Today's presentation here in early breast cancers, also there is a role of neoadjuvant therapy, right? Yes. In early breast cancers. So my question is, those patients, subset of patient who has undergone the neoadjuvant chemotherapy and the patient has complete response, right? Patient doesn't have, say on examination, there is no disease, and on mammography also there is no disease. So what will be the further line of treatment for such patients?
Sir, at present, these patients should undergo surgery. So before starting a neoadjuvant therapy, ideally we could put a radio-opaque clip or marker at the base of the tumor, so that once I give a neoadjuvant chemotherapy and the whole tumor disappears, it would be very difficult for the surgeon to operate and to find the tumor. It happens many times, sir.
Yeah. No doubt, today's reliability of the cancer diagnosis is mainly on true cut biopsy rather than fine needle aspiration. And so also we get more information on core biopsy like ERPR and HER. And on that basis, we can plan all treatments prior also, whether it is early or late. The only clarity from your lecture today is it's not only that surgery is the first line of treatment in all early breast cancer. Am I right?
Yes, sir.
Yeah.
But there is always a role of surgeon.
Yeah. Of
Without
course.
surgery, it is not going to
Right.
get cured.
That's why I deliberately cleared from your side that even though there is a complete response, surgery has to be done. Right? Yeah. Okay. Anything,
If
sir?
there are
Sanjay?
no further questions, we'll go for the third speaker,
Okay.
Dr. Samiksha Dubey.
Yeah, I think.
So can we present e-memento first
Yes,
to Dr. Saurabh, sir, please?
Yeah.
Okay.
Thank you, everyone. Thank you, sir.
Now coming to the third speaker, Dr. Samiksha Dubey. She is a student of D.Y. Patil, Pune for MBBS, and then she has done a MD from Jawaharlal Medical College, Savangi Meghe. And then she had done a DNB in a super specialty from PD Hinduja Medical Research Center, Mumbai. She has done the European Society of Medical Oncology certification, preceptorship course in a breast cancer. Then she has got a vast experience from 2017 till today, and she is at present at the Kingsway Super Specialty Hospital and also at RST Nagpur. Over to Dr. Samiksha Dubey.
Thank you, sir. Good evening, everyone. First of all, I'd like to thank IMA and the Association of Surgeons of Nagpur for giving me this opportunity, and of course, Kingsway Hospital. I'll just start with mine. I hope my slides are visible.
Yeah.
Yes.
I'll be talking about recent advances in the medical management of advanced breast cancer. The surgical and the early breast cancer part of medical part has already been extensively covered by both Dr. Bamanwar and Dr. Prasad. I do have an extensive PPT made for a lot of things because we do have a large armamentarium of treatment options available for advanced breast cancer in India and abroad. We already know why we are talking about breast cancer so much in India. It accounts for about 14% of cancers in the Indian women. The data for Indian women is 1 in 28 Indian women are expected to develop breast cancer during their lifetime. It's much more common in urban women as compared to the rural population. And it's seen unusually in a higher rate in a younger age group, which is extremely troubling as far as the treatment is concerned. Metastatic breast cancer is largely still remains incurable disease. The goal of the treatment here is just to maintain or to give a good quality of life to the patient and prolong the survival as long as possible. The most advances and the most recent researches have happened and extensively studied in the breast cancer molecular biology. And we have developed a whole lot of treatment options to improve the survival in such patients. And new treatment options are being found every year. There are breakthrough therapies which are much more safe and much more effective. And with advances of new targeted agents, we are moving towards the possibility of combination therapy rather than just chemotherapy alone. This is just to give an idea of what we are dealing with. We basically divide, as Dr. Prasad has rightly said in the beginning itself, that we need to do a true cut biopsy and to get an ER, PR, and HER2/neu reporting done on every breast cancer patient that we get. In advanced breast cancer, that becomes extremely important because we are diagnosing and we are treating according to these ER, PR, and HER2/neu report itself. So we basically divide these patients into HER2 overexpressed, hormone receptor positive, and triple negative patients, and accordingly, the treatment is decided for these patients. Now, since as you can see, we have a lot of chemotherapy options which has been developed, but in the last 5 to 10 years, we have developed a lot of other options like targeted antibody, small molecule signal induction inhibitors, immune checkpoint inhibitors, antibody drug conjugates, and there are still many more which are still in the development area itself. This is the current treatment paradigm. It does look very vast, but this is the current treatment paradigm that we are using in advanced breast cancer patient. First of all, when we look at the patient, the first thing that we want to decide is if the patient is in a visceral crisis, if there's any organ which is in the damage of or impending damage. In that scenario, we directly take up the patient for chemotherapy, irrespective of HER2, ERPR, or any other positivity seen in that patient. If the visceral crisis is not present, then we are dividing it into HER2 overexpressed, hormone positive. There's a small group of germline BRCA mutation and the triple negative. The first line for HER2 overexpressed patients are pertuzumab, trastuzumab, docetaxel. With each of these drugs, I've written in the bracket is the name of the trial, which has become the trial for getting this kind of approval in the line of treatment. The second line is TDM1, third line is capecitabine, lapatinib, and now there are other options of drugs which have come up in this third line setting. Hormone receptor positive, we are categorizing mainly into two: endocrine monotherapy, in which the patient just received one endocrine therapy agent, either aromatase inhibitor, tamoxifen, or fulvestrant. And in the second option, we have endocrine therapy plus the CDK4/6 inhibitor, which is sort of a game changer as far as the hormone receptor positive metastatic breast cancer treatment is concerned. Germline mutation, as we have already seen, PARP inhibitors, olaparib, talazoparib has been approved and shown very, very good responses in such patients. And the last one is triple negative. In those patients, till now, we have had only chemotherapy as the option, but now a small group of drugs, the immunotherapy, which is trying to penetrate in every cancer treatment now possible, has come into this criteria also. The TNBC or triple negative is the only area where the role of immunotherapy in breast cancer is still, we are seeing it. So HER2 targeted agents, we'll go through one by one. I'll try to be as short as I can be possible given the time constraint. HER2 is the member of a family of growth factor receptor, which is overexpressed in about 25% of the breast cancer patient and supposed to be associated with more aggressive phenotype. NCCN panel recommends an HER2 new testing in every patient. First of all, we are testing by IHC method, and if the patient is coming HER2 new 2+ or equivocal by IHC, we have to test it by FISH method. It recommends the first line therapy for HER2 new positive metastatic breast cancer is pertuzumab, trastuzumab combination with a taxane as the first line therapy, followed by the other regimen. As of 2020, there are 7 FDA approved HER2 new targeted agents for metastatic breast cancer: trastuzumab, pertuzumab, TDM1. These are all IV therapies, and of course, the newer one, the trastuzumab deruxtecan. And there are 3 oral ones: lapatinib, neratinib, and tucatinib, which are in approval for HER2 new directed therapy. The current approach is usually sequencing. First line is trastuzumab, pertuzumab plus taxane. It can be either docetaxel or paclitaxel. The Cleopatra trial actually used docetaxel in the regimen. The second line is with TDM1, which is the most common one that we are using. And the third line, we can use either lapatinib combination with capecitabine, chemotherapy with trastu, chemotherapy, all kind of agents, eribulin, vinorelbine. And now we have these 3 other options as well: trastuzumab deruxtecan, neratinib with capecitabine, and tucatinib with capecitabine and trastuzumab. This is just a version of the same thing in our NCCN guidelines, the American guidelines, which also suggest this, just give you an idea of the same things for second and third line. Going by the trials, I'll just try to be very brief about the trials. Cleopatra was the first trial in which it standardized the first line treatment of HER2-neu positive metastatic breast cancer with pertuzumab, trastuzumab, and docetaxel. It effectively showed a 16-month overall survival as compared to the other age group in this, group in this. After the progression on first line therapy, we are using TDM1. So for TDM1, we do have two trials, Amelia and Teresa trial, which showed it and proved it to be a standard second line therapy for HER2-neu positive breast cancer. In the Amelia trial, it was the combination of the TDM1 was the other group which was compared was with lapatinib and capecitabine, and in the Teresa trial, it was any treatment of physician's choice. Both showed a good response to TDM1 as compared to the other line. HER2-neu targeted antibody drug conjugate, that is the newest one which we have, is trastuzumab deruxtecan. This has a high drug antibody ratio. It has a stable linker, tumor selectable cleavage linker. It has high potency, and the antibody drug conjugate is basically an antibody which is humanized anti-HER2 IgG and monoclonal antibody, trastuzumab, along with a chemotherapy drug, in this case, which is a topoisomerase 1 inhibitor, which is linked by a linker and which is released and given through an IV form to a HER2-neu positive breast cancer. This was approved on December 20, 2019 as an FDA approval for treatment for unresectable metastatic cancer, given in a dose of 5.4 milligram per kg, 3 weekly in an IV form. Need to check the 2D echo, left ventricular ejection fraction prior to initiation. And since it contains a chemotherapy part as well, the blood parameters also needs to be monitored regularly for these patients. Based on the overall response rate and it was in the phase 2 Destiny Breast 01 trial, this drug has been come into approval. The median PFS in the trial for the drug was 16.4 months, and the overall survival is not yet reached. Neratinib, the fifth drug in the approval for HER2-neu targeted therapy, was approved basically on 25th of February 2020. It is approved in combination with capecitabine for the adult patients with advanced or metastatic HER2-neu positive breast cancer who have received 2 or more prior anti-HER2 based regimen in the metastatic setting. This was approved based on the NALA trial, NALA trial, in which it has shown a benefit in the PFS as well as the OS, though not statistically significant, but there was an improvement which was significant in the PFS for this combination of drug. Tucatinib, the last one in approval, has received an approval on April 17th of 2020 in combination with Trastu and capecitabine for advanced unresectable patients, even with brain metastasis, who have received more than one previous HER2-neu targeted therapy in the metastatic setting. It is given orally, 300 milligram twice a day with or without the food, and the dose adjustments can be made according to the hepatic impairment or the tolerance of the patients. This approval was based on the trial, phase 2 trial of HER2 CLIMB, in which it has shown an improvement in the primary endpoint, which was the PFS. It has shown a 46% reduction in the risk of disease progression and a 34% risk of reduction in the risk of death when added to trastuzumab and capecitabine combination. Now, these are the 7 drugs which are already approved, and there are certain more drugs in the HER2 positive metastatic breast cancer setup which are still in trial. Some of them are quite of tongue twisters. Margetuximab is a novel HER2-neu targeted monoclonal antibody which has the same specificity and affinity to HER2 as the trastuzumab. However, it has more potent stimulation and immune activation as compared to trastuzumab. There is a Sophia trial which has margetuximab compared to trastuzumab along with chemotherapy, has shown a better response as compared to trastuzumab itself. There's a specific new subtype which has started to come up now, which is HER2 low breast cancer. We right now in our guidelines, when we check the patient, we either call it HER2 positive or we call it HER2 negative. Either it is IHC3 positive or a FISH positivity for HER2. HER2 low breast cancer is common and represents around 50% of the all breast cancer patients. This is what we are calling something which comes HER2 positive or HER2 positive, but which is FISH negative. So this is more common in hormone receptor positive compared to TNBC. It's more commonly luminal subtype, a higher prevalence in metastatic compared to the primary setting. Antibody drug conjugate for HER2 new appears to be more promising in this subset of patient. If that is likely more due to the delivery of a cytotoxic agent rather than the HER2 inhibition, I'm not very sure about it. There are current HER2 new testing methods are insufficient in identifying such patients with very low level of HER2 positive expressions, and there's still some work that needs to be done in this area. This is how it does look like when we are testing the IHC samples, HER2 positivity and HER2 low and HER2 negative. So 34 to 63% of the breast cancer patients are considered HER2 negative under the current treatment guidelines. They do express low levels of HER2 positivity. If there is going to be a change in the treatment for these patients, we are still looking at it. The efficacy of trastuzumab deruxtecan, the newer ADC, antibody drug conjugate, in that subtype of patients of HER2 low has actually shown a better response. It is still in the pipeline. From HER2 positivity, we come to the ER positive or hormone positive breast cancer. Our latest guideline, American guidelines, the major improvement that has happened is addition of CDK4/6 inhibitor to the current hormone therapy, therapies like aromatase inhibitor, tamoxifen, or selective ER downregulators like fulvestrant. This is approved in first, second, or subsequent line of therapies for treatment. So initial treatment was AIs are considered to be the current standard of care for initial treatment of postmenopausal women with HER2 positive advanced breast cancer. Aromatase inhibitor has been compared with tamoxifen and has shown an improvement in such patients. So goes for the fulvestrant. Progression on endocrine therapy for for hormone positive advanced breast cancer. 50% of these patients will respond to the initial endocrine therapy, but will eventually relapse. There are multiple mechanisms which allow for the development of resistance to the anti-estrogen therapy. Delayed systemic chemotherapy is the preference here when we are treating a hormone positive breast cancer, advanced one. Adding a second anti-estrogen to inhibit the estrogen receptor pathway does not improve the outcome. Inhibition of both estrogen receptor and pro-growth or anti-apoptotic cell signaling pathway may improve the therapeutic outcome. In this, we do have a PIT inhibitors, which we are using now. Novel therapies now for metastatic cancers. As Dr. Prasad has already said, CDK4/6 inhibitors, there are 3 available in the market as of now: palbociclib, ribociclib, and abemaciclib. All 3 of them have shown improvement when they are combined with AIs. And these are the 3 landmark trials: Paloma 2 for palbociclib, Mona Lisa 2 for ribo, and Monarch 3 for abemaciclib, which showed a good improvement in the PFS when it is combined with an aromatase inhibitor in metastatic hormone receptor positive breast cancer. Let's say we have used the CDK4/6 inhibitor in a patient of hormone receptor metastatic breast. So what is the optimal treatment once this patient has progressed on already a CDK4/6 inhibitor? The options which we have are either you switch the hormone therapy and maintain the same CDK4/6 inhibitor. You either maintain the hormone therapy and switch to another CDK4/6 inhibitor or a targeted agent. You maintain the hormone and CDK4/6 inhibitor and add a collateral pathway inhibitor like PI3K/mTOR inhibitor to your current treatment regimen. These are the options which are available for us. We did not have a lot of data till now about switching the CDK4/6 inhibitor on progression, but there is some data which is available on abemaciclib now. Trial with for abemaciclib after the progression on palbociclib in the patients with HR positive HER2 new metastatic breast cancer. This was a retrospective analysis which showed a continued benefit from the treatment with abemaciclib following the previous CDK4/6 inhibitor therapy It was observed in about 1/3 of the patient. Trinity 1, the third option, which I was telling about, an addition of another pathway. So with this, we have ribociclib, everolimus with combination of exemestane after progression on a CDK4/6 inhibitor. This is a phase 1-2 study of continued use of ribociclib plus everolimus and exemestane postmenopausal women. Triplet therapy has demonstrated a clinical benefit following the disease progression on CDK4/6 inhibitor. In this study, the primary efficacy endpoint was met. The benefit may depend upon the tumor genetic profile also. There was no new toxicity signal by combination of by adding a third agent in this study. Now, another targeted therapy in breast cancer advanced, we basically talk about molecular therapy and the targeted therapy itself. So the latest one is PI3CK inhibitor, which is alpelisib. They are all a lot of tongue twisters. It was the landmark trial for approval for this was SOLAR-1, and the primary endpoint for which was PFS and secondary endpoint was OS PFS in PI3CA non-mutated cohort. I'm not going into extensive details, but the conclusion in this trial, in patients with hormone receptor positive, HER2 negative, PI3CA mutant advanced breast cancer and recurrence progression on or after the prior aromatase inhibitor therapy, addition of alpelisib to fulvestrant significantly prolongs the PFS versus the placebo plus the fulvestrant. The OS data is not yet mature. Hyperglycemia was common on-target adverse events with alpelisib, typically observed early in the treatment and was transient, but it was manageable with oral antidiabetic therapy. The last one, we come to a triple negative metastatic breast cancer. It's a subtype which is defined either by what it lacks, basically absence of all the ER, PR, and HER2/neu. Approximately 50% of the patients' breast cancer are TNBCs. It's generally recognized as chemo-responsive. Nonetheless, the vast majority of these patients have poor survival outcomes as compared to other breast cancer subtypes. Patients with metastatic TNBC progress very rapidly on chemotherapy with a very short median OS that ranges between 12 to 18 months. We have had the most common thing that we are using, or the only option that we have had was, so in systemic therapy was chemotherapy. Now we do have addition of platinum in triple negative breast cancer and immunotherapy along with BRCA mutation in triple negative breast cancer. So the current usage of chemotherapy, sequential single agent chemotherapy is preferred rather than the combination, which should be used or reserved for the patients which are requiring a more rapid response, but it does not improve any overall survival. We do have taxanes, anthracyclines, antimetabolites, microtubule inhibitors, as well as platinum agents. Patients should generally remain on a regimen until the best response, disease progression, or a significant toxicity. The challenges in treatment is relapse is very common in TNBCs in the first 2 years. Rebiopsy of metastatic sites should be done for a discordance. And the factors which affect the treatment choice here are tumor burden, rate of disease progression, performance status, previous therapy, which the patient has already received, and patient's preference. Since we are looking at quality of life and improvement on the survival and not a cure, patient's preference should always come in our treatment choice for diseases. There are other guidelines than NCCN that we do follow. So the European Society ESMO guidelines, the main point that I do want to highlight here is in triple negative advanced breast cancer, regardless of the BRCA status, previously treated with an anthracycline with or without a taxane in the neoadjuvant or adjuvant setting, carboplatin demonstrated an comparable efficacy in more favorable toxicity profile. So we do want to add a platinum, is shown to have a very good response in addition to other drugs in a triple negative breast cancer. Immune checkpoint inhibitor, the immunotherapy that everyone is talking about, and in every cancer nowadays, the subset of patients in which immunotherapy is approved in breast cancer is advanced TNBC. So we have a trial IMpassion 130 for atezolizumab plus nab-paclitaxel. The clinical outcome for patients with metastatic TNBC still remains very poor with a median OS of 15 to 18 months on standard chemotherapy. In this phase 3 trial, They demonstrated the addition of an adding of PD-L1 inhibitor to nab-paclitaxel in untreated metastatic TNBC PD-L1 positive patients. The median PFS was improved from 5.5 months to 7.2 months. And there was no benefit which was observed in PD-L1 negative patients. So it does need for us to check for the PD-L1 levels. Current analysis report, second interim OS analysis, 80% mature from impassioned trial. Conclusion was in patients with untreated metastatic or unresectable locally advanced triple negative breast cancer, PD-L1 positivity of more than 1% predicts survival benefit with atezolizumab versus placebo in addition to nab-paclitaxel. The second immunotherapy drug that has been approved is pembrolizumab in 200 along with combination with chemotherapy, which was the landmark trial for this was Keynote 355. The final analysis conclusion was the improvement in overall survival from 16.1 month to 23 months and PFS from 5.6 months to 9.7 months. Safety outcome was consistent with profiles for each regimen and no new safety concerns were seen in this trial. One important aspect that we do see in advanced cancer is bone mets. We do get many skeletal related events and we have been traditionally using bisphosphonates, either zoledronate or pamidronate in this area for reducing the skeletal related events. But we do have a drug called denosumab, which has come into our armamentarium and in the trials have shown it still remains superior to zoledronic acid in delaying or preventing the skeletal related events in patients with advanced breast cancer and bone metastasis. The very last of this is BRCA mutation positive metastatic breast cancer. So olaparib and drug has been assessed and has shown a significant improvement in the PFS when assessed when compared to the treatment of physician's choice. Median PFS was improved by 69% with olaparib treatment compared to the standard care chemotherapy. Talazoparib is the second drug which was approved in a phase 3 trial called EMBRACA. And it also showed at a median follow-up of 11.2 months. Progression-free survival was 8.6 months compared to 5.6 with a physician's choice of therapy. So future directions which we have is a long decades of basic and clinical research are now transforming metastatic breast cancer into a more chronic disease with improved survival and quality of life. Targeted therapies are moving into the clinical practice, offering promises of better efficacy with less toxicity. And the ultimate goal for the treatment is to individualize the therapy with each patient with metastatic breast cancer. Thank you so much.
Thank you, madam. It was an excellent presentation for advanced breast cancer disease and what are the different options available for the treatment of the metastatic breast disease. Now, this is a metastatic breast cancer disease is a very challenging because what you say in case of malignancy is not the quantity of life, but it is the quality of life which is more important than the quantity. Now, once breast cancer has advanced to such a metastatic disease, now patient's agony has increased to a great extent. Now, on top of that, if you are giving a chemotherapy and it has produced the side effects, then patient's life will be more horrible or from bad to worse. Yes. And that's why all the drugs, whatever you are going to select, should produce minimal complications with a maximum benefit as far as the patient is concerned.
Yes.
In the chat box, there are no further questions. So, Dr. Deshmukh, you want to ask any question?
Yes, Dr. Samiksha, it was a very nice presentation. And the overview of so many drugs that was just going beyond my imagination. And so many drugs are being introduced and few drugs are going to get introduced in the next, say, few months or year. Yes. The only thing is that in all metastatic breast cancer, with the varied choice of drugs, when the treatment of the patient should be stopped?
Sir, ideally we do in a metastatic breast cancer setup, treatment should be stopped when we don't have a treatment or when the patient's performance status has gone down so that they cannot receive a treatment, or when the patient has a choice to say no to the treatment. These are the three areas when we should stop the treatment in metastatic setup.
Because we have so many options, and the one drug is showing the superiority of 5 months, 3 months, 4 months to previous drugs. So the survival is being counted in months. So in such variety of choices, there has to be some end point. No doubt these are very much advanced patient what I'm talking to, and probably the all newer drugs or targeted therapies, these are very costlier drugs for all patients.
Yes.
And that may be the end point when the patient is not affordable for those targeted therapy, and our traditional drugs have been finished and the patient is deteriorating. Probably that may be the end point for such patient. It is just a social question, that's all. Yeah, sir, we can shift to other session.
Yeah, the memento.
Yeah.
Thank you so much.
Now we go for the last speaker. The biodata has not been sent to me. He is going to talk regarding radio imaging for sentinel lymph node biopsy and imaging of sentinel lymph node in various malignancies. Over to Dr. Sandeep Jaipurkar.
Yeah, Sandeep, welcome. Nice to see you after so many years.
Hi.
Yeah.
Hi, Sudhir.
Yes.
Yeah.
Yeah.
Nice to see you again.
Yeah, right.
Okay. Can you hear me? Am I audible? Yeah.
Yeah, you are visible and audible both.
Thank you, sir. Thank you, sir. Good evening, everyone. Respected Chief Guest, Dr. Dasgupta, sir. Respected Chairpersons, Professor Dr. Lanjewar. My dear friend Sudhir, President Association of Surgeons, Nagpur. President IMA Nagpur, Dr. Sanjay Devtare. Convener Dr. Shahnaz. Honorary Secretary Dr. Sachin Gathe. Other IMA office bearer and my dear friends. At the outset, I take this opportunity and thank IMA Nagpur for this honor. Today, we are going to discuss about intraoperative detection of sentinel node. When there are various different techniques for intraoperative imaging. These are all not relevant for sentinel node, but just for the sake of completion, I am enumerating all those. CME is the oldest one and widely used in orthopedic surgeries. CT and MRI, particularly neurosurgery. Ultrasound in all general surgeries. Gamma probe in some selected surgeries. And the latest one is the fluorescence imaging. When this topic was given to me, sentinel lymph node, I was just wondering what is the exact meaning of sentinel. So I referred to dictionary. The exact meaning is a soldier or guard whose job is to stand and keep watch. So is it right meaning? Because this node is not actually guarding that region or particular body. It is not preventing the spread of cancer. It is just standing there only because of its anatomical position. In medical dictionary, the same word, sentinel, the meaning is an indicator of the presence of disease. Again, the sentinel node may be positive for metastasis or may not be positive for the disease. So it's like calling the watchman of Samsung showroom, guardian of galaxy. It may not be true like that. So what is sentinel node? It is a node which receives direct lymph drainage from the primary tumor. So we are going to discuss this fluorescence imaging, which is the latest technique, and it uses the near infrared technology. This is the only modality where the surgeons can visualize blood perfusion as well as lymph flow. As you already know, any ionizing radiological equipment will show only the blood perfusion. We never see the lymph flow. But fluorescence imaging, we can see both perfusion of blood as well as the lymph flow, and without using non-ionizing radiation. The various applications, like in open surgeries, it can be used in oncology, breast, oral, penile, vulvar cancers, plastic and reconstructive surgeries, lymphedema, wound management, hepatobiliary surgeries. Similarly, in minimally invasive surgeries, colorectal surgeries, cholecystectomy, endometrium, SLNB, hepatobiliary surgery, and bariatric surgery. This technique is very much useful because it gives anatomical as well as physiological information. The dye or the medicine which is used is known as ICG or indocyanine green. It's an approved drug by FDA, very safe. Actually, in pharmacology, this is considered as the most safest drug in the pharmacology. It is non-ionizing, so no radiation. It binds with the lipoproteins to generate fluorescence. It is excreted through bile, so hepatic impairment is always a contraindication for using ICG. Its short life is just 3 minutes. So suppose you want to repeat after say 15 minutes, again you will have to inject ICG. It can be given after every 15 minutes. In India, it is available as Oro Green. It comes in a bottle of 25 milligrams sterile powder. It has to be diluted in 10 to 20 ml distilled water. The maximum dosage is 5 milligram per kg. So safe dose is around 2 milligram per kilogram. So how does FGS work, or the fluorescence guided surgery works? It requires two components. One, we have seen the fluorescent agent, that is ICG. Second one is near infrared imaging device. And very few companies make this device. Most of them are foreign companies, and India, IRILIC, that is the Indian company based in Bangalore, they have started manufacturing totally indigenous unit, and it is much better than all these foreign companies and cheaper also. It works in the near infrared spectrum, that is between 700 to 900 nanometer. So how does it work? Suppose if you are targeting a breast cancer and sentinel lymph node, so you inject peritumoral or a retroareolar area. This is the ICG injection, and this is the near infrared camera or the device. The fluorescence is happening, which is captured by the camera and displayed on the monitor there. So let us discuss about SLN in breast cancer. Why sentinel lymph node biopsy? Approximately 30% patients with negative clinical exam will have positive node in axillary lymph node dissection or ALND. So concept of SLN comes here. Lymphatic spread is not only orderly, but predictable. Histological status of SLN is predictive of the distant nodal basin. That means suppose SLN is involved, the possibility of the distant nodal basin is very high. Skip metastasis practically do not exist in breast cancer, and metastatic spread can be found by SLN route. So if SLN is negative, you can be 100% sure that there is no distant spread and ALND can be avoided. SLN can be single or it can go up to 5, or the number can vary. So that can be detected by this fluorescence imaging. Mostly we get SLN in axillary group of lymph nodes, but other groups also can be involved. And these are internal mammary, supra and infraclavicular group of lymph nodes. So this is a diagram. Suppose this is the cancer here in the breast. This is the nearest lymph node, and lymph drainage is happening to this node. From there, it is going to second layer or tier 2 lymph nodes. This is how the tumor dissipation happens. This is the tumor, and through the lymphatic channels, it is going to the nearest lymph node or the sentinel lymph node. You can see there is no direct, or this second tier or a second level lymph nodes are not involved, and they cannot bypass the sentinel lymph node. It will happen through or via sentinel lymph node only. And from there only, again, the third level lymph nodes will be affected. So detection of sentinel lymph node is very much important when you are dealing with small breast cancers. It is not preferred in breast tumor larger than 5 centimeter in size. Dr. Bowman has already told about this thing. I am anyway repeating again. Previous breast surgery or axillary surgery, palpable axillary nodes before surgery, multifocal tumor, occult primary, where the breast tumor is not found at all. Now, there are different methods to find sentinel lymph nodes. The oldest one or the commonest is the radioisotope with gamma probe. Second is methylene blue. This is the cheapest one. It's a powder type, and it has to be made into liquid and inject into the tumor or the peritumoral area. And the latest one is the ICG or indocyanine green, fluorescence imaging. The problem with the radioisotope with gamma probe, there are a lot of restrictions or regulations when you are handling radioisotope. You have to take permission from BARC, and the person who is handling this isotope should have a certificate. So it is not possible always to do sentinel node lymph node biopsy using radioactive dye. This study was done in Tertiary Care Cancer Center in Eastern India for during this ICG machine testing, and you can see the number of patients were gradually decreasing. From 2014, there were only 58 patients. Gradually, it came down to 12 by the end of 2018, because it's very difficult to get radioisotope dye and inject and use the gamma probe to find sentinel lymph node. That's why it is not so popular. When surgeons were given the option of ICG and methylene blue, they were a little skeptical about the use of ICG. So that's why both were tried together and see the sensitivity. Now, here both dyes are injected. The only problem with methylene blue is that you cannot have any navigation facility. You have to use only your eyes. When you open, you have to see for staining of the lymph nodes. But ICG means you have got a navigation facility. Now, both dyes are injected and you don't see anything with the naked eyes here. But you put the camera, ICG camera or fluorescence camera, and you can, this is the site of injection, which is fluorescing, and these are the lymph channels. These are the lymph channels. When you open that particular area, this is the stained lymph node because of methylene blue. Now, the camera, when was used for the fluorescence, 2 lymph nodes were detected, while methylene blue showed only 1 lymph node, ICG showed 2 lymph nodes. So slightly it is superior to methylene blue. The sensitivity is almost 27%, 97%. Is SLNB better than ALND? Yes, the morbidity. ALND is the leading cause of decreased cancer-specific quality of life. Post-operative complications, we get about lymphedema is about 3 to 10%. Numbness, some patients, or in 30 to 60% of patients, they complain of numbness, and chronic pain or neuritis in about 20 to 30% of patients. Early breast cancer will have clinically negative axilla, so difficult to decide about ALND. Level 1 lymph node less than 2 centimeters, so cannot be palpated. 75% negative beyond SLN, ALND can be avoided here. So if SLN is negative, the patient need not undergo ALND. Suppose if it is positive, in the same sitting you can do ALND, or suppose the frozen section facility is not available, the protocol is that you call the patient after 1 week when the report is ready and can take the patient for ALND. Again, revisiting the same with ICG, injection is done here, lymphatic channels going to the sentinel node, and these are the second tier lymph nodes. So this diagram again stresses that second level or second tier lymph nodes cannot be directly metastasized by the cancer bypassing the sentinel lymph node. Can you play the video, please, Piyush?
Yes, sir. Hold on.
Please. I will just show how this works. This is a short video. Can you see the video?
No.
Okay, okay. Piyush will help. No problem.
Yes, sir. I'll just stop your sharing so that I can share.
Okay, okay. Just stop it. Stop it.
Can you see the video?
Yes. Means the first, yeah, it must be starting, right? Started.
This one. So this is how the indocyanine green is used. First, you prepare the solution, okay? And shake the bottle very well for 3 minutes. There is a special filter so that no powder is brought inside the syringe. This filter comes along with the drug. When you make the ICG in solution form, it is green in color. That's why indocyanine green. Now we are injecting in the periolar area, and this is the probe of immediately the fluorescence starts and the lymphatic channels are seen here. And this is how the lymphatic channels are going, and this is the area where you are expecting a sentinel lymph node. You can massage with your finger so that the transit of the ICG will be fast. And this is very gently you can massage. And we are not targeting the tumor, we are targeting the lymph node. This is just preoperative. We are just mapping the sentinel lymph node. And here it is being marked. Now this is the marking. So the sentinel node will be here. So when you open, you can see that area. This is fluorescing, very bright, shining. You cannot miss it. There are 2 lymph nodes here. Impossible to see with naked eyes here. But when you open and see, and with methylene blue also, you can see that it is stained. So it was combination of ICG and methylene blue. The surrounding area is also fluorescing. This is the lymph node, okay? And fluorescent nodes, even if when you are taking it out, they will remain shining or fluorescent for some time. Okay, go back.
Back to your presentation, sir.
Where to go? Share the screen.
Yes, share the screen.
Where is my thing? Yeah, okay. How to make the whole screen, full screen? Can you get it, Piyush? Okay.
No,
So,
sir, not yet. You'll have to go to full screen.
Okay. Full screen not coming. Okay, this is other applications, sentinel node in CA penis. The same technique. Now this is the tumor here. You are injecting the ICG near the tumor site. As soon as you inject, because of the perfusion, the penis as well as the tumor is fluorescing. You are not seeing the sentinel node in this particular picture. You will be seeing it in next picture. So here it has gone to the sentinel node, and preoperative marking. This is the one node, second node, third node. So there were 3 sentinel nodes, and these were marked by the ICG camera. After operating, you can see this node which is fluorescing taken out, and these are the 3 nodes, 1, 2, 3. On the hand, you don't see anything. Without the camera, it doesn't fluoresce. Other different applications, oral cancer. Now this is an oral cancer primary site, and this is the lymph node here. Scalp cancer, this is the lymph node. Endometrial cancer, this is the sentinel node. Vulvar cancer, another node here. Stomach cancer, this is the node here. So what are the advantages? You get anatomical as well as physiological imaging. So we have seen this sentinel node mapping. In lymphedema screening also we can get. So it is very important in lymphedema surgery, liver segmentation. Physiological imaging, as you can see the blood flow. So free flap planning, flap perfusion, flap monitoring, amputation level, diabetic foot perfusion, liver perfusion, organ perfusion, particularly in anastomosis, colorectal. This is very important. We use second video. Can you play?
Sir, I don't have a second video.
I sent it. Okay, not there. Okay, it was for the lymphedema. I sent you the link. Did you check the second one?
I'm checking, sir, it's not there.
Okay, leave it. So that video was for lymphedema. When you inject, now this is the normal lymphatic pattern and this is the lymphedema, which call it stardust appearance. The lymphatic channels are not seen here, and here also you can see splash-like picture, and here it is diffuse. So if you are planning lymphovenous shunt, the exact location of the lymphatic channel can be judged before the surgery, and you can select that particular channel, and the shunt can be done. So this is also very important for primary lymphedema, then post-surgical lymphedema. This is again can be mapped before surgery, and the surgery can be done here. So this technique is quite useful for SLN mapping as well as flap surgeries and this lymphedema surgeries. Lot of lymphedema clinics in South India, they are using this technique, and they are getting fantastic results.
Sir, I have the video. You want me to play that?
Yeah, please. Can you show that? You got it?
Yes, sir.
Please. Yeah. So this is for lymphatic. So normal side. Okay. So lymphatic channels started as soon as you inject, the lymphatic channels start, getting opacified or fluorescing. These are the normal lymphatic channels. Just see this normal. And now this is a lymphatic lymphedema. See, no lymphatic channels are seen. The contrast of ICG is just stagnating here, and we are getting the star flash picture. This is called a star dust or star flash, as if the stars are there twinkling in the dark sky. So these are the aborted or obstructed lymphatic channels. The continuation is disrupted here. Suppose a surgeon wants some shunt here, he can choose and make it lymphovenous shunt. So this is very important for a plastic surgeon to detect a lymphatic channel, which is impossible otherwise. See, there are different lymphatic channels, but very vague. This is not like the other side. It's total obstruction here. Okay, thank you. Go back. Yeah. So thank you very much, sir. And again, I thank IMA Nagpur for giving me this opportunity to share my experience. And it was a great honor to meet my old friends. Sudhir was a very good friend of mine when I was in Medical College Nagpur. Thank you.
Thank you, Dr. Sandeep. It was a very good demonstration of the indocyanine green visualization fluorescence technique. And what is the which company is manufacturing in India, and what is the cost of the machine?
See, this company is known as Irelic, and that is Irelic, Bangalore based. And I just want to share, actually, it is my invention. This machine is my invention.
Very good. Congrats.
Thank you. And we got Best Innovation Award for developing this machine. There is 2 years back.
Congrats for that.
Otherwise, only few companies, Western companies, foreign companies, they are making, and they cost is somewhere above 75 lakhs rupees. But in India, it is around, we are making it for 30 to 35 lakhs rupees.
Over to Dr. Deshmukh.
Yeah. Sandeep, it was a very excellent presentation and demonstration of your machine. I must also congratulate you for the innovation of this machine. Sentinel node biopsy is a really a very interesting topic for all oncosurgeons, because the sentinel node is being discussed almost from last 20 to 25 years, and there are few methods of getting detected. I mean, sentinel node detection by, say, methylene blue and all those previous methods. I find your method is very really very helpful. And the other utility of this method is nowadays the surgery for lymphedema is being practiced widely, because that is one of the major morbid condition post surgery in most of the few patients of say cancer breast, in which this lymphedema surgery can be very well offered, and this can be in all lymphatic channel or lymphovenous anastomosis can be better achieved with this your machinery. So I must congratulate the utility of this machine. The cost is around 30-35, you said?
Yeah.
Okay, right. Yeah. And now the variety of the other oncological procedures, they are also now using sentinel node biopsy in different conditions. Especially, primarily it was started with cancer breast, and no doubt in clinical practice we often see the problems of cancer penis also, because the standard teaching from last 25 to 30 years, just clinically negative patient, observe the patient, treat primary, then wait for 1 or 2 months, give antibiotic. If there is a recurrent, appearance of the nodes, then try the groin node dissection. So all these methods were the approximate methods of detecting metastasis, but the fluorescence technique can really help in and reducing the morbidity of the groin node dissection also, because as axillary node biopsy, axillary node dissection is a morbid condition. Equally, the groin node dissection is also a morbid condition, in which we face so many post-operative complications of that groin. So these are 2-3 areas where this sentinel node fluorescence technique will be very much useful. And no doubt it is now widely used to avoid lymph nodal dissection in so many other conditions like colon and other liver. So I must congratulate you again. And it was really a very nice lecture and good elaboration of your machine and utility of your machine. Thank you.
Thank you.
Excuse me, sir. Can I speak?
Yeah, please.
So Sandeep has one more very nice patent, which he's very shy to speak about. And since it is relevant, he's got his, has a attachment to the mammography. I would like Sandeep to say something about that. Sandeep, can you please elaborate on that?
Okay. Uh, what Shehnaz is talking about is thermal mammography. Again, it is a physiological imaging. We detect temperature changes in the breast using this thermal camera. What I feel, we have most of the radiological equipments are based on this X-ray, that particular radio frequency. This electromagnetic spectrum, what we are using is between infrared and near infrared. And there are a lot of applications which can be used and exploited. So I thought of using thermal camera, which we are widely using for temperature detection in COVID times. Same camera, but it is more sophisticated. And I have mounted it on a robotic arm, and the patient lies on a table in the prone position. And the breast actually is one breast is examined at a time in a prone position. The camera, thermal camera, rotates around the breast around by 360 degrees, and it stops at every clock position, say 1 o'clock, 2 o'clock, 3 o'clock, and captures the image. If there is a subtle change in temperature at that particular area, it can be captured and displayed in the camera or the monitor. So the temperature difference of say 2 degrees Celsius is suspicious of something going wrong. It may not be cancer, it may be inflammation or something is wrong. That means it's a physiological change is happening. So even you can predict that the cancer can develop in that particular area, or instead of this breast screening, this is the best screening tool. Instead of subjecting a patient for radiation again and again or compressing the breast again and again, this is a better method. I call it as rotational thermomammography, and you have got a US patent. Unfortunately, this startup failed, and that's only sad part of it. Because of the, want of money, nothing else.
You can try again.
All now NCLT has taken over all those things.
We apologize, Sandeep, because it would have been a pleasure to introduce you. The amount you have achieved, we are all proud of you in the 81 batch. And it is very sad that somehow your CV got missed, and we apologize for that.
No problem.
Because I know the amount you achieved, and now latest is he's drawing cartoons depicting medical cartoons, and he's got even a book published on it, and he's into patents and startups. So thank you, Sandeep, for being with us today.
Thank you, Professor.
Piyush, momento, please.
Sharing.
Yeah, Sandeep.
Thank you, Sudhir.
Yeah.
Thank you, Sudhir. Yeah.
I request Pratibha to conduct to.
Yes, sir. Yeah, it was indeed a very informative session. I really thank the speakers, and I would now like Dr. Devtade to please present the mementos to the chairpersons as well.
Piyush, mementos, please.
Sharing.
Yeah, thank you.
Sudhir
Thank
sir,
you.
thank you very much.
Thank you.
Saurabh, thank you very much for a nice
Thank you, sir.
lecture.
Thank you, sir.
Sandeep, it's a pleasure to listen to you again and again.
Thank you. Thank you, sir.
Samiksha madam, thank you very much for
Thank you, sir.
coordinating the CME.
Thank you, sir.
Nanjawar sir, thank you very much being
Thank you
part
very
of
much,
this
Devdare.
CME. Thank you very much, sir.
Thank you, sir. Thank
Nitin
you,
sir,
sir.
thank you very much for a nice
Thank you so much,
lecture.
sir.
Sir.
Thank you all for a successful CME.
Thank you.
Now I request Dr. Sachin Kate, Honorary Secretary of IMA, to please give the vote of thanks.
Thank you, Pratibha ma'am. And on behalf of IMA Nagpur, today's CME, actually this is a breast cancer awareness month. So this the event will go on for whole month, actually October month. So on behalf of Indian Medical Association and in association with Kingsway Hospitals, I thanks to our Dean Academics, Director Medical Services, Dr. Dasgupta sir, for being a chief guest in the CME and guiding us, giving a word of inspiration. He himself is a oncosurgeon and has a vast experience in the field of breast cancer. And I also thankful to our chairperson, Dr. Lanjar sir, Sudhir Deshmukh sir, President of Association of Surgeons, our speakers, Dr. Nitin Bomanwar sir, a well-known oncosurgeon working in King's Hospital, Dr. Saurabh Prasad sir and Dr. Samiksha Dubey madam, oncophysician from King's Hospital, and the last Dr. Sandeep Jaipurkar sir for his innovation. I am very thankful for our today's MOC, Dr. Pratibha Dhingra madam. Thank you very much. I think Piyush, do you have a memento of Pratibha madam?
No, sir.
No, okay. So I will hand over to it. No problem. She is my colleague only. So I thank you for conveying this CME from almost from getting recognition from MNC, coordinating with the chairperson, speaker, Dr. Shenaz Chintanwala ma'am, our very own vice president. Thank you very much. And I also thank you to the MMC and MMC observer, Dr. Jagdish Kotari sir, surgeon, eminent surgeon from the city of Nagpur. Thank you very much. And I thank you all the participant who has patiently watched this CME, listened to the speaker, chairperson, and discuss various issues. And also thankful to our digital partner, DigiShield, Dipen, Piyush. Thank you, Piyush, for coordinating this event. Many more events are coming up from IMA Nagpur, a mega event that is our annual conference, NIMACON, Nagpur IMA conference. Please participate in it, register for it, and we need your support in future also. Thank you very much.
Sir, I have a moment of Dr. Pratibha ready.
Yeah, please show that. Thank you, Pratibha ma'am.
Thank you, sir.
Yeah, thank you. So we can log out. Thank you.
Yeah, thank you, everybody. Thank you.
And happy Gandhi
Bye.
Jayanti.
Good day.